Hi, I'm Dr. Kuang, a urologist specializing in men's lower urinary tract symptoms, or LUTs. Much of my work focuses on recognizing bladder dysfunction in men. Today we'll discuss overactive bladder, or OAB. The prevalence of OAB in men in the United States is about 15%, roughly the same prevalence as in women. OAB is often underdiagnosed and undertreated in men. One reason is that historically there has been greater emphasis on the prostate than the bladder when evaluating men with urinary symptoms. Differentiating between OAB and BPH in men is complicated by the frequent occurrence of both storage and voiding symptoms and the fact that symptoms can sometimes overlap. As a result, when men present with LUTs, about 2/3 or 62% receive a diagnosis of benign prostatic hyperplasia, or BPH. And about 3/4 of these men, 74%, receive BPH treatment, such as medication. The truth is, for many men with urinary symptoms, it's actually bladder dysfunction, specifically OAB, not just a prostate problem. Consequently, only about 26%, 1 in 4, receive an OAB diagnosis, and just 7% receive OAB medication. Let's pause for a quick question. What do you think the answer is? If you said OAB is associated with storage symptoms and BPH is associated with voiding symptoms, you are correct. Separating OAB from BPH can be a real challenge because men often experience both storage and voiding symptoms, and those symptoms often overlap as men can experience bladder dysfunction, OAB, or a tightening prostate, BPH, or some combination of both. For the bladder, the storage symptoms of OAB include urgency, frequency, nocturia, and urge urinary incontinence, or UUI. For the prostate, that is in the shape of a donut, the voiding symptoms of BPH are due to an enlarging prostate that is constricting the flow of urine. They include hesitancy, weak or interrupted stream, dribbling at the end of urination, urinary retention, and the sensation of incomplete bladder emptying. Historically, many of these storage or irritative symptoms in men were attributed primarily to the prostate. Today, we recognize that these symptoms reflect bladder dysfunction, an overactive bladder. Here is another question for you. If you said all of them, you are correct. Failing to differentiate between prostate and bladder causes of symptoms can have important implications for treatment outcomes. In men with persistent storage symptoms, it is important to pause and consider that the bladder itself may be contributing to symptoms. For BPH, alpha blockers are commonly used, but they may not adequately relieve OAB symptoms. Other pharmacotherapies for BPH include 5-alpha reductase inhibitors and phosphodiesterase 5 inhibitors. On the other hand, beta-3 agonists and muscarinic antagonists are prescribed for OAB. For treatment of OAB in patients with BPH, guidelines from the American Urological Association suggest monotherapy with either a beta-3 agonist or muscarinic antagonist, or combination therapy with an alpha blocker. When storage symptoms are prominent due to some combination of BPH and OAB, therapies that target bladder physiology may be appropriate. Gemtesa is a beta-3 adrenergic agonist indicated for the treatment of OAB with symptoms of urge urinary incontinence, or UUI, urgency, and urinary frequency in adults. And for the treatment of OAB with symptoms of UUI, urgency, and urinary frequency in adult males on pharmacological therapy for BPH. Gemtesa is contraindicated in patients with known hypersensitivity to vibegron or any components of Gemtesa. Hypersensitivity reactions such as angioedema have occurred. Please see the full important safety information at the end of this video. Gemtesa is the only beta-3 agonist approved for the treatment of OAB in men who are being pharmacologically treated for BPH. Courage was a 24-week, phase 3 multi-center randomized, double-blind, placebo-controlled study that assessed the efficacy and safety of Gemtesa in men receiving pharmacologic therapy for BPH. Primary endpoints included change from baseline in average daily number of micturitions and average daily urgency episodes at week 12. Secondary endpoints included change from baseline to week 12 in average daily urgency urinary incontinence episodes and volume voided per micturition. In fact, in the Courage clinical trial among men receiving pharmacologic treatment for BPH, Gemtesa reduced average daily urgency episodes, average daily micturition frequency, and average daily UUI episodes. In this study, adverse events occurring at an incidence greater than placebo and in 2% or more of patients included hypertension and urinary tract infection. In summary, OAB is common, affecting 15% of men in the U.S., yet it remains underdiagnosed and undertreated. Differentiating OAB from BPH can be challenging because storage and voiding symptoms often overlap. Many men with urinary symptoms have contributions from both the prostate and the bladder. And recognizing the bladder component is critical to choosing the right therapy and management strategies. Gemtesa is the first and only beta-3 agonist approved for the treatment of OAB in men who are receiving pharmacologic therapy for BPH.
Indications and usage. Gemtesa is a beta-3 adrenergic agonist indicated for the treatment of overactive bladder, OAB, with symptoms of urge urinary incontinence, urgency, and urinary frequency in adults. Overactive bladder, OAB, with symptoms of urge urinary incontinence, urgency, and urinary frequency in adult males on pharmacological therapy for benign prostatic hyperplasia, BPH. Important safety information. Contraindications. Gemtesa is contraindicated in patients with known hypersensitivity to vibegron or any components of Gemtesa. Hypersensitivity reactions, such as angioedema, have occurred. Warnings and precautions. Urinary retention. Urinary retention has been reported in patients taking Gemtesa. The risk of urinary retention may be increased in patients with bladder outlet obstruction and also in patients taking muscarinic antagonist medications for the treatment of OAB. Monitor patients for signs and symptoms of urinary retention, particularly in patients with bladder outlet obstruction or patients taking muscarinic antagonist medications for the treatment of OAB. Discontinue Gemtesa in patients who develop urinary retention. Angioedema. Angioedema of the face and/or larynx has been reported with Gemtesa. Angioedema has been reported to occur hours after the first dose or after multiple doses. Angioedema associated with upper airway swelling may be life-threatening. If involvement of the tongue, hypopharynx, or larynx occurs, immediately discontinue Gemtesa and provide appropriate therapy and/or measures necessary to ensure a patent airway. Adverse reactions. Most common adverse reactions greater than or equal to 2% reported with Gemtesa were headache, urinary tract infection, nasopharyngitis, diarrhea, nausea, and upper respiratory tract infection. Please see accompanying full prescribing information.